ಸರ್ ಹ್ಯಾಂಡ್ ಟು ಹ್ಯಾಂಡ್ ಸ್ವಲ್ಪ ಹಿಂದೆ
ಸಾಕಾ?
ಸೂಪರ್ ಸರ್ ಸಾಕು. ಅಯ್ಯೋ ಸರ್ ಹೋಯ್ತು ನನ್ನ ವಿಡಿಯೋ
ಸ್ವಲ್ಪ
ಹಾಂ ಸರ್ ಆಯ್ತು ಸರ್.
Very casually we met in a function, and then I start discussing with Niti madam, maybe just 2 meetings maybe, and then so today we are all here. So it just says that we were all waiting for a connect to happen, and I think nature has connected all of us for this cause. So while the flap there tells you what it is all about, so you just need to take up a saliva in a cup and then hand it over, or maybe even a swab, and then ultimately the whole DNA gets sequenced. Or at least the relevant genes get sequenced. So we want to do this for a couple of reasons, apart from just being on the.
Can we do anything about it? So these are the wellness things which can be done. Whether we already spoke about cardiovascular risk, gastro risk, of course cancer risk, but can we prevent lifestyle? Can we predict lifestyle and nutrition and what needs to change? Can we optimize by exercise? So exercise optimization. Can we do personalized screening, which could be higher for one individual and not so much for the other individual? And of course, something known as a family cascade testing. So if you are positive, do your first degree relatives need to be tested? So you could have your siblings, your parents and your kids as first degree relatives, and some of them are autosomal dominant conditions, some are my dear colleagues and friends, firstly a very warm welcome on this afternoon. Well, as oncologists, we deal with genomics all the time. We have patients who walk in with a disease, but our whole goal is to find out, can we change this landscape? Can we predict a person can actually have cancer? And can I have slide change? Can we actually find out that what are the things which we can do to actually patient to prevent having this possible problem? And well, yes, we have something known as preventive genomics now. Well, we can predict the person, not just who has cancer, but so many other conditions like a genomic condition, a genetic condition, and also whether can it be customized, can it be individualized, and we can tailor-make therapy or tailor-make prevention to that particular patient. And this is what is known as blueprint. This is known as genomic blueprint. Like everybody has a unique fingerprint, we have genomic blueprint, and that's what I'll try to unveil right now. Try to give a little scientific presentation, mostly symptom-based. We have a problem, we reach out, and we try to find out. The doctor tries to find out solution. But what has changed in 2026? We streamline them into certain high-risk groups or standard risk groups, so we can customize treatment. And this is the theme of oncology hematology, a tailor-made treatment, a custom-made treatment, which is very unique to that individual. And we have been talking about this for almost 15 years now, which is becoming sharper and sharper. But what is actually the difference between genetics and genomics? When we talk about genetics, we more talk about single gene variant. Whether this particular gene is there in one individual and are like thalassemia, like sickle cell. Do they have a gene variant and they may actually have sickle cell in future, or they have thalassemia at that point in time? But what is genomics? When we talk about genomics, we are looking at a larger landscape. We are looking at the entire DNA, sometimes the RNA and the protein expression of that individual to what they can potentially have. And yes, it's an extremely powerful tool. When we talk about genomics, it's the beginning of an extremely powerful tool. And when we have this powerful tool, it comes with a lot of responsibility. And this is what each one of us as doctors need to dwell on and deliver at the right time to exactly what is needed. Not do beyond that, or possibly not even miss a candidate who is a potential candidate for getting these kind of tests. So why does genomics matter? Well, it goes hand in hand with a clinician. The power the genomics deliver goes hand in hand with the clinician, and our power is becoming stronger and stronger. Again, as an oncologist, cancer has been the poster boy for genomics. And this is what we do at this point in time. Well, a decade back, it was just general treatment. We had a disease and we had one solution. And that solution may bring good result to one individual, may not deliver to the another individual. And what changed is sequencing of the DNA, sequencing of the RNA, and therefore more and more customized or personalized treatments were delivered. Every patient, every cancer has unique targets and of course minimum effective dose. So pharmacogenomics is the genomic part of the drugs which tells us what exactly is the dose a person will benefit from. A person could be a fast metabolizer or could actually be an intermittent metabolizer, and therefore the drug dose will differ from individual to individual. And as this slide rightly says, if there's a poor, we can actually do something to prevent it. There are other conditions like severe hypercholesterolemia, and predicting hypercholesterolemia and management early on. Then of course cardiomyopathies, which are an important segment. QT interval prolongation, but again, can anything be intervened at the right time? And of course, all this is not in isolation. Everything is in tune with a cardiologist's advice. Is there any hepatic disorder, or we know the largest disorder across the globe now is non-alcoholic steatohepatitis. Who are at risk of those kind of disorders? What are the solutions? And then of course, we have a small problem and we may be actually utilizing the solutions forever and we don't know whether we have hit the right solution or not. So a common problem like a severe constipation. Is there a metabolic link? Is there a genomic link to that problem? You would hear that somebody in the family is taking pantoprazole or rabiprazole, but there's no effect. And then keep on coming back that I have no response, I have this problem. So what we knew was that cancer is a disease of the genome. But what we know now is not just the DNA. We actually sequence the RNA, known as transcriptonics. We should know the tumor microenvironment, how the tumor behaves in whether it's in the bone marrow, it's in the lung, or it's in the liver. So the tumor microenvironment is extremely important. Beyond that is the environmental factors. Can methylation do a different thing? Can the environmental factors actually interplay in a different way for manifesting? Every patient will come and ask, I am a smoker, but the other patient who was not a smoker got cancer, and why did I not go? So yes, there is a play of DNA, there's a play of RNA, a tumor microenvironment, and of course environmental factors. And now, as Sir was just saying, proteomics has mass spectroscopy as the root, but at this point in time we still need integration in normal